Okay. So yesterday, the big take home message that I was trying to talk about is the contraction, or the contraction of the heart, or the squeezing of the ventricles um, is the mechanical activity. The electrical activity is triggered by the SA node. The SA node is also known as the pacemaker of the heart. So that when it sets the pace, it sets the pace. It is going to make sure all the cardiac cells move in the same direction, but they have to be in coordinated fashion. And that's why it'll go through on the picture of that. Let me go back to that picture a second. There's these kind of little red dots here, and those are kind of like it's like they can hold the signal and send the signal. So when the SA node fires, it'll have to go through all those fibers. And because those fibers, the Purkinje fibers, are in the ventricles, once the impulse reaches there, they're going to fire. Now, you will have a class later, you talk about arrhythmias, or an abnormal rhythm. If for some reason these fired before the SA node, that is what causes an arrhythmia. If any of these fibers or part of the electrical conduction system, if at any point it misfires or out of order, that's when we see the abnormal rhythm on an EKG. So when I hammered home about I don't hate EKGs, they can be accurate. If we see an abnormal rhythm and then we listen to the heartbeat and it sounds abnormal, then the dog probably has an abnormal heartbeat. So I always just say, whenever you see an image on an EKG and it doesn't appear normal, that you need to look or listen to the heart or feel for a pulse and see if it's matching what you're hearing to what you're seeing. And that's the most important message. Now, what happens here is what we call a cardiac cycle. The cardiac cycle basically is one heartbeat. And in that one heartbeat, you have atrial contraction, then ventricular contraction, then relaxation. And then when that happens again, that's the second heartbeat. So 2 words that you need to know that are on this slide is systole and diastole. And systole is the myocardium actually contracting, okay? When it squeezes, that is systole, that is systolic contraction. Diastole is when the myocardium relaxes and it's repolarizing. Think relax, repolarize. But if you remember, in order to get those muscles to contract, you had to send a nerve impulse. Remember, depolarization is when the polarity changes and then the signal is sent. That initiates the muscle contraction. But it has to always go through a repolarization before it can depolarize again. So what I really talked about yesterday was systole, diastole, systole, diastole, systole, diastole. When the heart is in diastole, when it is in relaxation, that is when the chambers can fill with blood again. And that is when the myocardium receives its blood from the coronary arteries. Remember the kitchen sponge. If your heart is squeezing, the muscle is like a sponge, okay? It's squeezing. It's not going to absorb as much blood. When it's in diastole and the sponge is relaxed, then it can fill, okay? So the take-home message is, when we talk about heart rates in animals and we talk about normal heart rate, cats are pretty universal. Most cats are going to be upwards of 180 to 220. They have a very high heartbeat rate. It's very abnormal to get a cat below like 120. Like if a cat came in for a physical exam and I took its heart rate and I got 120, I'd be very concerned and like, why is this cat's heart rate so low? Now, for a Great Dane, or say you had like an Irish Wolfhound or a Newfoundland, a very, very extra large breed dog, if that dog had a heart rate of 180, I would be extremely concerned. The bigger the animal, the slower the heart rate. The bigger the animal, the slower the heart rate. I think a mouse heart rate's like 300, like you can't barely even count it. The littler animals have a higher metabolism. They have a higher heart rate. As we get bigger, their heart rate slows down. But think about it. If you have a horse and they have this very large heart, it's going to pump. It has to spend enough time in relaxation to fill. Now, I always want to try to have people make mental connections. If I was to say to you on a test, how does a fast heart rate affect ventricular filling? What do you think I mean? And you can unmute yourself if you want to take a stab at it.
Less time for it to refill back up.
And what'd you say?
There's less time for, sorry, my dog's barking. There's less time for the heart to fill back up.
Amen, amen, amen. So the faster the heart is beating, the less time that it spends in diastole. And then when it squeezes again, it's not going to have as much blood to squeeze out. That's a very important physiologic process to understand, because when we talk later in anesthesia or cardiac diseases, how does tachycardia affect a patient? If their heart is beating too fast, they don't spend enough time in diastole. The heart chambers don't fill with as much blood, and the heart muscle doesn't have as much time to perfuse, and then the heart muscle doesn't get enough oxygenated blood. And the heart muscle doesn't like that. That's when we could potentially see arrhythmias and problems with the heart, because the heart is a muscle and it needs oxygen, okay? So again, when you get into certain breeds, and when I teach anesthesia, we talk about this because, dogs are all over the map. A Chihuahua and a Great Dane are going to have different heart. Everyone used to say dogs' heart rates shouldn't go below 60 beats a minute. If it's a Great Dane, I am perfectly okay with a heart rate of 55 or 50. If I'm a Chihuahua and I have a heart rate of 55 or 50, I'm sweating bullets, if that makes sense. So dogs are going to be a little bit different based on size versus like a cat. All horses are about the same. Cows are about the same. Cats are about the same. It's really when we get into dogs that we have this wider range of heart rate based on their size. So, but I want you to know also, each chamber has systole and diastole at different times. Remember, the atria contract first. So the atria are going to go in diastole before the ventricle, okay? So it should be atria, ventricle, blood out the body. And it should follow that pattern. Now, when you listen to a heart rate, and I don't know, like I said, how much you guys got to do that yet before you leave, and don't worry, we'll get all that experience. We don't want anybody to fall behind. But if you have your stethoscope at home and you can listen to your own pets at home, especially this is good. If you have a relaxed pet at home and they're sleeping, just go ahead and listen to their heart. And you should hear this lub-dub, 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 boom, 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 boom. What you're actually listening to are the valves. The sounds, lub-dub is made by the valves closing. So the lub, which is the first sound, happens after atrial systole. So as the atria contract, they're going to push blood. And remember, the valves have to open, okay? After the blood goes through, those valves are going to snap shut. That's the lub. The dub is after the ventricles contract, and that's when the pulmonary and aortic valves open and shut. So it's lub dub, lub dub, lub dub, lub dub. Now, this is great if you're listening to kind of a really chill dog, if you've got heart rates under 160, you can usually hear a decent lub dub. But remember, lub dub is one beat. Lub dub, lub dub, lub dub, lub dub. Some people do lub dub, lub dub. Like, there was a big old Labrador and the student said, oh, his heart rate is like, 160 or something. And I was like, that's kind of high for this dog. And then I go over and I get 80 because they had counted the lub dub twice. So they doubled the heart rate. So and that's common to do when you're first learning how to do it and hearing the sounds, but lub dub is one heartbeat. Now, if you have a cat that has a heart rate of like 200 or something, you're probably going to hear dun, 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 and those you're counting individually, because the faster the heartbeat, you're not necessarily going to hear that lub dub. The heart's just going too fast. So that's why I said normally your animals at home, when they're resting or sleeping, and you can kind of slide a stethoscope on them, you'll probably hear this better than, when you guys get to those dogs in the kennel and they're like, human, human, and they're super excited and their hearts are going very fast. They're typically going to be faster for you guys, but that's why I always say practice at home with your own animals. They're on the couch or they're on the floor, they're sleeping, they're kind of chill. You're going to be able to do some of this stuff a little bit better. Okay, so lub dub, lub dub. I just want you to know which valves are closing when what is happening. Now, what I started to allude to the other day is that an abnormal sound of a heart, you should hear very sharp, bump, 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 bump. We don't want to hear like a swooshing. Swooshing, or sometimes people call it a washing machine heart, is when you get these murmurs. So what happens is there's two reasons for murmurs to happen. There's something called valvular insufficiency and valvular stenosis, okay? In insufficiency, remember the gate. Here's the atria, here's the ventricles, okay? When the atria contract, the gate opens, and then it should close. Open, remember, it doesn't flap in the wind, okay? Open, down, snap shut. If one doesn't close all the way, okay, so say it goes like this, and then instead of this one coming to snap shut, that part of the gate always stays open. So they do this, but do you see this gap? Blood can go backwards, and then that's what causes turbulent blood flow. On the other side, stenosis is a narrowing. Anytime you hear the word stenosis or stenotic, it's narrowed openings. I'll give you an example. Pugs sometimes have these really tiny nostrils. They are called stenotic nares. Nares is the opening to or we call nostrils, we call nares in dogs. At Purdue, we had a surgery for this where we made little cuts right here where we cut their nose and we tacked it open. I called it little doggy plastic surgery. And it was really to help them breathe better because their nasal opening is too narrow. It's stenotic. So I can use the word stenotic in a lot of different areas. Aortic stenosis would be an aorta that's narrow. In a valve that's stenotic, what happens is instead of opening all the way, you might have one that's opening and this one is kind of staying there. But do you see, instead of it being nice and open, you've always got this one in the way. So what happens in this case is blood tries to push around this, but sometimes gets pushed backwards because it won't get out of the way. That causes anything that causes backward flow. It can also cause turbulent blood flow. And the turbulence is the sound you hear. Now, I don't know if everybody remember day one, Ireland was talking about a case and the heart looked a little big or the atria was enlarged. So if you look at an x-ray of a heart, if you have a stenotic valvular stenosis, what can happen is every time the blood tries to push, it can't go past this. It'll push backwards. And what it does, it can start to put pressure on the atrium and the atria enlarge. So in severe cases of valvular stenosis, you can see atrial enlargement. And it comes because all that friction not going that way starts pushing backwards and it squeezes it open. Does everybody understand that? Or if there's any questions about that, stop me and I can explain it. The other thing I will mention, it's not on this slide. Well, mitral disease, we can see this in like older dogs, and it tends to be a little more of the toy breeds or the little guys that tend to get the mitral or tricuspid. Mitral valve is the one that tends to be implicated the most in this disease. And we grade murmurs. I'll put a note here. So I typed it in the chat screen. When an animal has a murmur, now as a technician, you guys normally go in the room, meet the client first, get a history. I usually get a heart rate, listen. I do like my little physical. Obviously, the doctor's going to do a physical. If I hear this swooshing, all my job is to tell the doctor, hey, I think this dog has a murmur. I think I hear an abnormal sound. The doctor is going to put a grade on it. And I don't know why it doesn't start at 1. Okay, there's 6 grades of murmurs, but they start at 2. If a dog has a 2 out of 6, and we write it like this, kind of like a sideways fraction, if it's a 2 out of 6, that's a pretty minor murmur. And it can go all the way to 6 out of 6, which is the most severe murmur. A 6 out of 6 dog, when you listen to the heart, you almost hear just shh. It's almost hard to hear an actual beat. It kind of just sounds like all this swooshing. There's medications, and a lot of times it depends if the dog is showing symptoms. There's some people that never treat their dog with a murmur, and it doesn't get very severe. But if you have a dog that's coughing, lethargic, exercise intolerant, not eating, then it can be the murmur is interfering with a good quality of life, and we can give them medications. It doesn't get better. You just have to treat the symptoms. So, does anyone have any questions about murmurs? You can get stenosis if you remember there's valves. There's a valve at the pulmonary artery and there's a valve at the aorta. There is pulmonic stenosis and subaortic stenosis. Those tend to be seen more in puppies and can be more severe and can be very dangerous for the puppy. Because a subaortic stenosis, what's happening is blood is being limited to leaving the aorta to go to the body. And then what happens in that is that the body doesn't get adequate oxygen. Sometimes these dogs, these puppies pass out. They're playing and all of a sudden they flop over because the brain doesn't get enough oxygen because the body can't, the left ventricle can't push out that stenosis. So in severe cases, subaortic stenosis or a pulmonic stenosis, those are more like puppy, but when we talk about the valves in the heart, they tend to be seen as an animal ages. Okay. Any questions about that? Okay. One thing to understand, and a very important concept, is something called cardiac output. That literally means how much blood is being output through the heart. When the heart squeezes, how much blood is leaving? And we measure this at the level of the left ventricle at the aorta, okay? We are not really concerned. Remember, the right side of the heart is pumping to the lungs, okay? That has the easy job because the heart lives between the lungs. It's like you walking over to your neighbor's house for a cup of sugar versus walking 2 miles for a cup of sugar, okay? Right ventricle just pushing to the lungs, but the left ventricle is going out the aorta to the body. So what we need to know is how we calculate this is how much blood is ejected out of the heart in 1 minute. We take stroke volume. Stroke volume has to be measured by an ultrasound, a cardiac ultrasound. Okay. So US stands for ultrasound. Now, heart rate, you just get a heart rate on the dog. So if we measure stroke volume during the procedure, and then we get the heart rate, you multiply that, that gives you the cardiac output. I do want you to know this calculation. Not that you were going to have to do this calculation. I just want you to know the formula. CO equals SV times HR. Cardiac output equals stroke volume times heart rate. And what we are literally measuring is how much blood is leaving the heart. Now, the stroke volume, what is that telling me? It's telling me how strong is the heartbeat. When the heart goes boom, 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 pushes out blood, how strong is that? Is that strong enough to meet the need of this animal? Is it strong enough to reach every area of the tissues of the body? But think about the heart as like a pump, which is what I've been telling you. The heart can only squeeze out what it has. Preload is how much blood has come from the left atrium to the left ventricle. Do you remember, and go back to what Tia said, remember when I asked a question, I said, if you have a very fast heart rate, what does that do to filling time of the heart? It decreases it. So let's look at how does that affect preload. If my heart is beating super fast and it doesn't spend enough time in relaxation, which is diastole, that is going to decrease my preload. So think about the ventricle. The ventricle squeezes and then it has a crappy cardiac output. It has a crappy stroke volume. The heart's like, dude, it's not my fault. I didn't get enough blood from the left atrium. The left ventricle's like, I can only pump out as much blood as I get in my ventricle from the atria. So preload is what is coming in to the heart, okay? The volume of blood from the atrium to the ventricle. Now, the next step in the equation is the ventricle is squeezing against a tube called the aorta. And the aorta is connected to every artery in the body by a series of, different vessels. If this artery is this size, and then all of a sudden it's narrowed to this size, that's going to affect something called afterload. If I gave everybody a Slurpee straw, one of those really big straws, you get the Slurpees, and I say, okay, blow up this balloon. I'm going to attach it to the straw. And then I said, hold up a minute. I take your Slurpee straw, I'm going to give you one of those little cocktail stirrers for coffee. And those tiny little straws. You're not going to be able to blow as much volume of air through that straw as much as you could a Slurpee straw. That is afterload. The size of the vessel, the heart's trying to push out, but it's like, dude, it's not my fault. That vessel's all narrow. That's called vasoconstriction. So if for some reason all the systemic arteries are vasoconstricted or narrowed, that is going to affect or decrease afterload because the heart cannot push as much blood because they're all narrowed. So this becomes important when you guys get into fluid therapy, because fluid therapy in an animal that's severely dehydrated, sometimes they're tachycardic and they have low blood pressure because they do not have as much blood volume. If we give them a bunch of IV fluids and we boost their volume in their vessels, that is going to increase or help preload. I can give drugs to affect the vessels and improve afterload. Okay, so what I'm telling you, the big summary here is if we do a cardiac ultrasound and we don't like the number that we get for stroke volume, now obviously the heart, if the heart has a heart muscle disease like myopathy, it could affect the strength of the heartbeat, but we have to look at any disease that affects preload, any disease that affects afterload, because that is a piece of the puzzle. Hopefully that makes sense. You know, the heart, what's interesting, complex but a very simple thing. It's just sitting here all day doing this, okay? It is pumping blood, but it is connected to all of these pipes, these vessels. So when we look at diseases or problems with the heart, you cannot just always just look at the heart. We also have to look at what's happening with the whole body, what's happening with all the vessels, because it's an interconnected system. And if you only look at one thing, we could be missing the bigger picture. Now, I've already explained every animal has an intrinsic heart rate, which is mean your base heart rate. Humans, we have a heart rate. Normally when you are at rest, that is the best time. And it is to check it. And that is set by your SA node. Your SA node sets that intrinsic rate. Now, when that rate goes up or changes from your base rate, it is typically responding to the autonomic nervous system, which is what I explained yesterday. If you have sympathetic stimulation, it's going to go up because the heart is responding to a need in the body. Parasympathetic stimulation brings the heart rate down, but that's a signal that we're going back to rest and relaxation. The SA node is still what sets the rate. The nervous system does not set your heart rate. Okay, that is the SA node, and it will fire continuously as long as you're alive. The nervous system will change the rate and force of contraction based on need of the nervous system. Okay, and I've already explained, the larger the dog, the slower the heart rate, or the larger the animal. Horses under anesthesia, heart rates are about 40 to 50 beats a minute, sometimes in the mid-30s for a horse. But if I'm a Chihuahua, I need to be up there in heart rate. So, okay, and then the difference in an artery and vein in all of these systems in the picture, you know, there's arteries and veins. Arteries are red, veins are blue. But just look at the structure. A vein has these little valves in there. A vein doesn't have as much muscle. So there's the connective tissue on the outside. There is a muscular layer, okay? And then you have the inner part, which is the endothelium, and has a valve. So when the heart is in diastole, the valves are kind of trying to prevent all that blood from going backwards, okay? Now an artery is much more muscular. You can see all of that muscle. It has endothelium. it is a little bit thicker. This little connective tissue here is thicker in veins than it is in arteries. But an artery has to be able to adjust its diameter by changing that muscle. What's interesting about arteries too, and a little fun fact, if you work in emergency or a very specialized practice, you might get into doing arterial catheters. We went through a phase at Purdue where almost every patient got an arterial catheter. And the only reason we put in a catheter in an artery is to measure blood pressure or measure blood gases, which measure oxygen of the blood. If you work with horses, if you think your dream is to like do equine surgery or work in an equine practice, every horse under anesthesia, general anesthesia, is going to have an arterial catheter if they're in a hospital, not a field, but if they're in a hospital, because blood pressure is key. Dogs and cats, not so much, but when I would go to put in the arterial catheter, you put it near their dorsal pedal, which is right, it's distal to the hock, and it's medial on the back paw. If you put your fingers there on the medial aspect of that little hock area, you can feel their little pulse. And I would go to try to stab a catheter in it. It's kind of like a stabbing technique. You don't push like an IV, you have to like stab it. And then all of a sudden it would disappear. Because if I like nicked that little connective tissue of the artery, the muscle would spasm. And it was like it was hiding from me. I mean, you could feel it move and bounce away. And I'm like, where are you? Where are you? Where are you? It's like, you know, a vein doesn't do that. You hold off a vein, it's right there for you. Now, arteries, wherever you see a vein, there's a corresponding artery. But they lie a little bit lower. You know, arteries aren't, hey, I'm here. They're below. So the veins are more superficial. Now, the reason that the muscular layer is important in an artery, there's times in the body that if the animal is going to go through, well, we talked about vasoconstriction. When you have fight and flight, a lot of blood, the blood vessels, the arteries will vasoconstrict, which they'll narrow, and it will shove the blood that was in there, it will send it to another area, muscle, brain, heart, lungs. So when the signal comes from the nervous system to go into fight and flight, those muscles constrict the size of that artery, and then by nature, what was in there squeezes to another area. And that is why they have a more muscular, because arteries can change their diameter to affect blood pressure. And there's times in the body that happens by nature. There's times in the body where they have to affect their blood pressure. So an artery, the other rule to think about it, and this is important too, think artery away. Artery away. An artery is always carrying blood away from the heart. And this second line here, oxygenated blood through the body, systemic circulation. There is one exception to an artery that does not have oxygenated blood. Okay, if you go back to my picture, do you see this is called the pulmonary artery? And it's blue. It is an artery because it's leaving the heart. So it's automatically called an artery because arteries always leave the heart. But it contains deoxygenated blood because it's leaving the right ventricle and it's going to the lungs. So the arteries in pulmonary circulation carry deoxygenated blood. They are the one exception to the artery rule. Arteries always carry oxygen except in pulmonary circulation. The aorta is the largest one, and the arteriole is the smallest one. Anytime you add IOLE to a word, you're making it small. That's the smaller version of something. So the aorta is the largest one, very elastic. It can stretch, it can contract, it can adjust for blood pressure when need be. Now, a capillary is even smaller than an arteriole. These are those microscopic vessels, and they are capillary beds, and they are 1 cell thick. If you remember, when we did tissues, and I had talked about layers of endothelium. Endothelium is the inner layer of a blood vessel. Those are always 1 cell thick because I said, what is happening? There is exchange of gases, can be exchange of nutrients. So that is where the blood will give oxygen to the tissues, will give nutrients, and where it will diffuse wastes. A capillary is always the most terminal branch of a vessel. I'm going to come back to that. Veins are always going towards the heart, and they always carry deoxygenated blood, except pulmonary circulation. Okay, I didn't label this, and if you guys came in a little bit late, Sean was asking me this question. Okay, here was my picture, and there was these 2 vessels that I did not, it says see from lungs. These are the pulmonary veins. Now, the reason these are veins is because they're coming back to the heart. By nature, a vein is always returning to the heart. They came from the lungs, so they have oxygen. Normally a vein, do you see this right here? This is the mama vein, the vena cava. The vena cava just came back from the body. That is carrying deoxygenated blood. There is no oxygen in that blood. Normally, all veins do not have oxygen. Normally, all arteries have oxygen, except in pulmonary circulation, it's the reverse. Now, remember how I said things go big to little and little to big? After the capillaries drop off the oxygen, they pick up CO2, and then they're going to join venules, which are little veins, and then they're going to go to a vein, and then they're going to join the vena cava. All systemic veins, that means all veins from the body, the vein from your big toe, the vein from your leg, the vein from your kidney, the vein from your intestine, all dump into the vena cava. And then the vena cava is going to come into the right atrium, and it's going to bring that deoxygenated blood. And the way blood does not backflow is those valves. Imagine when the heart is in diastole, when it relaxes. Nothing is being pumped at that moment. So we don't want stuff to really go backwards. So the veins have valves that prevent that backflow. There's not names. We're not going over names for those. You only need to know the valves in the heart. But there are vessels there that prevent it from going backwards. So the little trick question here is, which blood vessel in the body carries oxygenated blood like an artery, but carries it towards the heart like a vein? The pulmonary vein, okay? So the pulmonary vein, it's a vein because it's coming to the heart. It just broke the rule because it has oxygen in it. But it got its name because it's a vessel coming to the heart. Arteries away, veins towards. Now, how we break this down, and I know I'll be finishing up because I want to get you guys to Nemur. Arteries carry blood away. Aorta is the major artery that goes to the body for oxygenated blood, and the pulmonary artery is the major artery that goes to the lungs. And then veins carry blood towards the heart. The major vein is the vena cava, which has deoxygenated blood. The other major vein is the pulmonary vein, and those are coming from the lungs. Now, yesterday, do you remember my road analogy? I said you're on Big 465, okay? You're on that big loop. And then all of a sudden you get off at 465 East, and then you get off at Emerson, and then you get off at 10th, and then you pull in your neighborhood, the road in your neighborhood, and then you pull in your driveway, okay? Do you see how I'm going from really big, heart, if you imagine right here should say aorta. I mean, it says artery. But if I go heart, aorta, artery, arteriole, capillary. Capillary is the driveway. You're at the driveway, someone gets out of your car. You're going to drop off oxygen to the tissues. And then CO2 is sitting there hanging out going, hey, I could use a lift back to the lungs. So it's like, okay. So at the capillary level, you dropped off oxygen and you picked up CO2. Now CO2, the blue capillary is going to join a venule, and then it's going to go into a vein, and then it's going to go in, right, this arrow should say vena cava, and then it's going to go to the heart. You went big to little, little to big. Now, when I see capillary here, this is a capillary somewhere in the body. It could be, yesterday I used the example of it went to the kidney. It could be going to the intestine. It could be going to your big toe. It could be going to your pinky finger. It could be going to your gums. If you've heard, when you do a physical exam, if you'd heard CRT, capillary refill time, when we go on the dogs and we push on their gums, and you work, what are you measuring? Well, it's 9:16. You're measuring perfusion. I'm going to stop there and I want to talk about that. We'll build this tracing of the blood flow, but I'll get in trouble by Nemer if you guys are late. So I don't want to make anybody late. Does anyone have any questions real quick?
No.
Nemer will get me. So
Yeah, she will.
no, you better not be late for Nemer. She is like punctuality is never my strong suit. So I usually give students a little more wiggle room just because I sympathize. But Nemer, man, she like, I love her to death, but I'm like, girl, it ain't that serious, but all right.
Thank you.
All right, you guys have a good day, and I'll get this recorded and send out, and I'll see you tomorrow, same time.
Bye.
Bye, have a good day. You too, have a good one. Have a good one. Let me do this. Okay. Got everybody.